We are now live, Chair.
Thank you very much, Janice, as always. Okay, good evening, ladies and gentlemen, and welcome to the Adults Health and Social Care Scrutiny Board on the 31st of August, the last day in August, and it feels like autumn already, and it feels like the year's just totally vanished extremely quickly. So welcome everyone who's joined us. Welcome to Katie. Thank you, Katie, for joining us this evening. And a special welcome to Libby Wiley, who's our new scrutiny support. So a warm welcome to Libby. I'm sure you will thoroughly enjoy our scrutiny, and you won't want to leave Calderdale ever, hopefully, is the idea. So welcome, Libby. So let's get on to the item of the agenda. We've got quite a busy agenda, so if we can keep our questions as prompt as possible, without quashing debate. So item number 1 is substitutes nominated for this meeting and apologies for absence. We've had no substitutes and we've had no apologies for absence. Item number 2 is members' interest, so to remind members to declare any interest at the appropriate time. Item number 3, admission to the public. The public are welcome to join us via YouTube. So anyone listening out there, you are very welcome, and we hope you enjoy and perhaps partake in a future meeting. Item number 4 is minutes of the Adults Health and Social Care Scrutiny meeting held on the 25th of July. I move those as a correct record. Councillor Hutchinson.
Can I just raise a question? There are quite a number of points in the minutes where we were told that more information would be provided to members regarding the Integrated Care Board service plans and priorities. So, about information about the community diagnostic centres, about the recognition of provision of alternative provider medical services, and quite a few of them that are there actually in the minutes, but I'm not aware that we've been provided with that information yet. Has a reminder gone to the chief officer of the integrated?
I'll ask Mike to chase that up if we've not already received that. Mike, do you want to make a comment on that, Mike Lodge?
I can't remember whether we've actually sent a reminder, but we will chase that up immediately after the meeting tomorrow.
Indeed. Other than that, can I move those as a true record? Seconded by Councillor Hutchinson and all approved? Yeah, superb. Okay, fantastic. So item number 5 is a new item to the agenda, and is deputations, giving members of the public the opportunity to raise a question 24 hours in advance, or a statement 24 hours in advance about items on the specifically related to items on the agenda. As it happens, we've had no deputations this time, but we would welcome them at future meetings to engage with members of the public to ensure that actually we are open to the public and listen to their comments and etc. So let's get on to the main items of the agenda. Item number 6, which is discharge to access. So we welcome Sean Cook. Thank you for the report. I don't know if you want to add anything additional to the report.
Thank you, Chair, and good evening, everyone. If I just briefly give an overview of the report and context in that sense. The approach that is a national approach, as the report outlines, is about, in essence, making sure that, and this came from COVID, if there were any of the kind of positive byproducts of COVID, it was that the health and social care system had to think very differently about supporting people in the community. So in essence, this over the last 3 years has been a move in Calderdale and elsewhere across the country to support people in their own homes who have been discharged from hospital. It's been kind of further complicated by the fact that in terms of the volume of people that are being discharged from hospital and going into hospital therefore as well, and the level of acuity that people have, the complexity is so much greater than it was even before COVID. So that would have been the case, I think, you know, over the years, because people are living much longer with long-term conditions. So the approach has been to make sure that even with people that have acute conditions, particularly around more complexity with EMI, people with dementia, then we have services that can support people in their homes. And of course, that makes sense. And it's been discussed many times before in different forums about people with dementia and people with health conditions who have been medically optimized being supported at home rather than in unfamiliar environments such as hospital. And we are now working towards a model that we're hoping to implement by October of this year. That is a whole system, adult social care, because it was relatively more simple for us, relatively more in terms of our numbers of staff, have moved towards social workers, and this will be the case with the health system as well, with therapists, physiotherapists, clinical leads, consultant doctors and practitioners, district nurses are already in the community, but more clinicians supporting people at home. And that will be linked to our new, if members remember the development, it's not that new now, but in December 2021, we developed the urgent community response team. And so therefore, the essence will be about keeping people out of hospital as far as the purpose of that team is concerned, and virtual wards in respect of clinical services going into people's homes to support them, and making sure that when they're being discharged, we have an eye on them straight away, and that in terms of the capacity that we have in social care, which is sufficient, it's good at the moment around home care and specialist services, people can be supported to remain at home safely. The issue is always, and we're going to keep a closer eye on this than ever, because I know that there is a paper that's been presented by Health Watch today, that because of the numbers of people we're working with across the health system, you know, safety and premature discharges for people with complex needs can be compromised and can obviously compromise a person's health and well-being. But the essence is to make sure that people are at home and not in residential care, even in short-term placements, which has been the case where they're deconditioning and then remaining in permanent care when they should be at home.
Thank you, Sean. Right, so we've got a number of questions. Councillor Barnes, first of all, please.
Yeah, I'm learning from the famous 1970s footballer Norman Hunter school of get your retaliation in first above Councillor Hutchinson by putting your hand up before the meeting starts. So thank you for that. The early hand was that. I'm not sure, but I really found this a really confusing and difficult report to understand. I'm not even sure what the pathway is. Is there not a simple flow diagram process that actually you can follow and understand how a patient will go from point A to point B? At what point a VLR, BABC, DEF comes in and affects them as D2A? It's just really just so complicated in this format. Is there not a simple process that we can look at? And within that, is there not some SLAs in terms of timeframes? Because that's the model we're talking about. And if we look at the reconfiguration of the hospital, and I know we can, and a few of us are on that, and we know the delays and the issues there, but one of the primary reasons for the plans that they have in place is the ability to move, a horrible phrase, move patients on, shall we turn around and say. But if this is the pathway they're going to, I don't know what pathway they're going to. And it just seems to be so difficult to understand and read it and see where they're going. If you are a layman, and we should be producing efforts and things like this for the layman. Sean, I understand, and Kath, you'll know this backwards, sideways and forwards. But anybody else looking at it, I read it 3 times, and the third time I was more confused than the first. Can we not produce some form of flow chart, flow diagram with SLAs, with points as to what days they occur? So when we scrutinise, when we come back and look at this and see, has it been successful, we can say, so how many people actually were seen in the 7 days that was said? How many weren't? And that's the business model you've built on. So we need to be able to look at and assess that business model. And this doesn't, I don't think this allows us to do it. Thank you, Chair.
Thank you, Councillor Baz. On top of that, to add on that, I think there should be something that the patient can take away as well, and that they know, literally on the same lines as Councillor Barnes, that they know from day one when the discharge as to what actually physically happens. And it could be a small little booklet that this is a takeaway with your digest read, and this is what should happen. So I don't know if you want to come back, Sean, on those comments, seeing what we can do.
Yes, by all means, I'll try and answer those. My apologies if it is confusing, and this is no excuse at all. But it is an incredibly complex system where, without going into the detail, people can either go into intermediate care beds because of their nursing needs. They can go into short-term discharge to assess beds. They can be supported home with different types of support. There are 3 pathways depending on the person's needs and their acuity that they can go to as far as those key pathways are concerned. There are a whole number, and what I didn't want to do, and my apologies, I've failed, is kind of confuse the matter further. One of the things that, and I think it's because of unfortunate timing more than anything else, we deliberately didn't include a pathway because we're still working on it. So exactly the question that you've asked, Councillor Barnes, is what we're working on as a health and social care system in Calderdale that we hope will be ready by October, and a number of people are working on that across the piece. If we were to have presented that today, even as a proposal, it would probably likely be changed in a week or two's time. That's not an excuse, but we wanted to kind of hold back on that, and by all means at a future scrutiny committee we can present that simply as the process that will be the process, hopefully definitively. And I've got to say, as winter kicks in, it always changes because it's a movable feast, but most certainly we could present that process that you've requested, Councillor Barnes.
Can I just come back on that? I know you said about winter, but the report specifically states that at some point, I can't find it at the moment, that this system will be fine in winter. That's at one point in the report, it almost says, "Oh, don't worry about it. Winter's going to be fine." I can't remember where it says something, but in there, it almost it's there's a.
Indeed, can I bring Kath Gormley into the conversation, please? We're not hearing you, Kath. There's something wrong with your sound. You don't look to be on mute.
Sorry, can you hear me now?
We can indeed. Yeah, that's most better. Thank you very much. Thank you. You've gone quiet again, so I don't know what you did before, but what you did before worked. So hopefully. No, we're still. You must have pressed a magic button. I think it's the volume from our side.
Chair, before Kath comes in, it's at the last paragraph in page 6. It says, "It is envisaged that with increased home care capacity and the appropriate use of reablement, winter pressure challenges will be alleviated."
Yeah, and that's the hope, that they will be alleviated in terms of the additional resources that we're going to give to the model.
So the business model needs to work in winter and summer. Is that right?
Yeah, absolutely.
Just to pick you up on that, Mike, pressure will be alleviated isn't the same as winter won't be a problem. I think we always recognise that winter's a problem, particularly for hospital discharge, but actually, health outcomes are better in people's homes, and we're trying to get that process working. So I hope that makes sense in terms of what we hope that the model will do. I do take your point about it not being as clear as it could be, but part of that is because there's quite a lot of different and fairly complex routes people can go through, but I think maybe that is something that we can and should go away and work on. We were looking at slightly simplified versions of our other kind of front door pathways earlier today, and I wonder if we could do, I don't want to use the word flow chart, but kind of, yeah, something that shows people's routes a bit more, a bit more plainly, albeit it would have to come with the caveat that these things are rarely consistent.
Thank you, Councillor Ventinglen. I'm going to bring in Councillor Prashad at the moment, and when Kath can join us, she's got technical issues. Unfortunately, we all have gremlins in the system sometimes, so it's your turn this time. It was Janet's turn last time, so it's your turn. So, Councillor, just before you do, just read out from Kath. I was going to say that Councillor Barnes makes a fair challenge about technical language, which is a very complex area, but point taken. So thanks, Kath, for putting that in the chat. That's most helpful. So, Councillor Prashad, please.
Yeah, I realise obviously this is not well, it's just the preemptive policy, but for patients who are being discharged to residential care home, we've had a couple of really big closures of care homes just recently, and I just wondered how that could impact on this discharge to assess.
Yeah, that's, sorry, Chair, did you want me to respond? Apologies.
Yeah, please, yeah.
Yeah, sorry. Thank you, Councillor Prasad. Yeah, we've had particular challenges over the last year, 18 months, with number of care homes in a small market closing, and it has added to the pressures as far as hospital discharge is concerned. We have commissioning arrangements with given homes to support people, and there are designated places that we pay for across the system, health and social care, for people to be, I referred to it earlier on, to be discharged into beds on a temporary basis, so that they can be supported if need be. If they can't go home straight away, then to go home, or if they are so complex it may not be a return home. So we're constantly working with providers to make sure that we've got sufficient capacity in the system. As I mentioned earlier on, there is really a good level of capacity now for home care, which we've been working on for a long time. And we are managing what is a very kind of delicate market with our residential and EMI. So just to extend that, the answer to your question, people with, it's called EMI, it's a very arcane phrase, but essentially people with complex dementia. There are very few placements for those people in Calderdale. We're able to accommodate them at the moment, but often it's in out of area placements. So in essence, to answer the question, it's a constant approach to kind of balance the market and the demands that we're having with the people that we need to kind of support to go into homes, and that's why we want to put more emphasis on supporting people at home rather than just in residential on a temporary basis.
Thank you.
Sean, just before bringing anyone in, is this where the business relationship managers come in? Do they
Yes.
And I suppose in that case, it's quite important that they, their continuity, I suppose, in terms of their care, because I suppose it's all about the care and actually ensuring that the relationships are sound.
Absolutely. You've raised a really good point there, Chair, in that the business relationships are a key conduit. So one of the key tensions that we've got is that the hospital are discharging large numbers of people. We're supporting that. And the registered care homes are saying, hang on, these people are very complex. We haven't been given time to support the assessment and understand the person. And therefore, we're not going to, quite rightly, kind of accept the person until we understand how we can, kind of properly and safely support them. And that's where the BRMs, the business relationship managers, come in. And in the paper, again, there is a reference to trusted assessments. So essentially, it's how can we get trust between the providers and the hospital in terms of the right information about a person that is sufficient for them to be safely and well discharged into homes. And it's again, to be honest in the answer, it's a constant it's a constant challenge that we're working on, and we have other roles now to support that with the BRMs to hopefully make that easier for folk leaving hospital.
Excellent, thank you for that, Councillor Hutchinson. You've come third. What's happened? I don't know why. I don't understand it, Councillor Hutchinson.
I have several questions, if that's all right, Chair.
That is perfectly okay, as always.
Yeah, thank you. I mean, any process in which there are a number of interfaces, particularly between different organisations and different systems, people can fall through the gaps in them. And Healthwatch did a study of discharge to assess in 2020, where they spoke to 600 people who'd experienced it, and 82% of them didn't receive a follow-up visit or assessment, and a fifth of those who didn't receive an assessment had unmet needs that should have been picked up at such an assessment. 60% didn't receive information about discharge processes during hospital stay. And 35% weren't given contact details of a health professional they could contact for support or advice after discharge. And Cumbria Healthwatch did a similar study last year. And obviously we've got a number of cases that have come to the notice of Healthwatch Calderdale, although as far as I'm aware, they haven't been going out specifically looking for them. Now, in the government guidance that was published in July, updated in July last year, it does say that local areas should agree governance structures that support clear planning, delivery and monitoring of performance and routes to escalate issues where required. I was wondering what the governance structures that have been put in place look like in Calderdale, and what sort of monitoring is actually taking place to make sure that if there are, and you've obviously picked up some issues with people not being told about the charging structure in Calderdale and various other things, but you know, how is it actually being done?
Sean, do you want to come in on that? And I'm sure Councillor Hutchinson has some other questions on top.
Sure, absolutely. I'll try and answer them as concisely and quickly as I can if there are other questions. First of all, as far as information on discharge, and it was a question that was asked earlier on, there is now a process in place whereby, and it should have been in place already, and it was partial more than anything else, but as part of the new level of investment that the system has received from the government to support this discharge to assess approach, people will be given information, including information which they have already, but again, much more fully, more consistently, on what they should expect when they're being discharged from hospital, and the charging arrangements, and how, you know, their support through discharge should take place. In terms of follow-up assessments, that is absolutely an area that we're focusing on as well, so that the additional resources that we've got in terms of social care assessors, OTs, they're working with the person and their family. Preferably, it depends on where they are in terms of their recovery, but usually 4 weeks after their recovery or discharge, to review their needs, to review their situation, to see if further support is required or less in terms of the rehabilitation. Reablement, the team that has been established for the last 20 years in Calderdale and across the country, that Councillor Barnes referred to, that's in the report, is very much at the core of supporting a person, and there are kind of key support plans for that person, outcomes to ensure that they're as independent as possible. So the investment, put very simply, is to give more consistency to those reviews and follow-up work once a person's being discharged. That should also include contact details of professionals. So if I'm discharged on Monday, I or my family members know who to contact in the community as part of the discharge to assess process to say, we need a district nurse to come in, or we need to speak to our GP or social worker about what's happening here, because we're not happy with, or we're not sure that the recovery is taking place as it should have done over the weekend. The monitoring of performance, again, it was something that Councillor Barnes had mentioned in his question to me. There is a whole suite of metrics that, again, we can present to a future scrutiny committee on exactly what the performance of this new model will look like that we haven't had before. And that will be at the centre of making sure that quality and quantity, but particularly quality, is in the right place as far as what we're doing well and what we're not doing well, which will always be in place. There are also forums within the hospital, key safety discharge forums, and certainly other forums through on a regular basis, such as the multi-agency discharge process, it's called MAID, that look at a person's safety and where there have been, and there are, unsafe discharges, that's followed up from a safeguarding perspective.
Councillor Hutchinson, do you have another question? You want to?
So, okay, so that information is actually collated so that, say if we wanted to, 6 months' time, we wanted to look at how well the system is performing in terms of the care that patients receive, we would be able to get that information.
Yes, as part of the work that's underway to prepare for winter, to, as the report stated, to alleviate the pressures and improve the system, the quality of care for people, there is a matrix, metrics, a whole number of metrics to reflect the performance of the working of the model.
If I may, Chair, again, in the government guidance, it says that there should be a transfer of care hub set up in each acute hospital, and to bring together all the relative services across the sectors: health, social care, housing, voluntary services. Does that transfer of care hub operate 24/7? If it only operates Monday to Friday or whatever, what happens during the times when it isn't operating? And obviously, there's a lot of people in Calderdale Royal Hospital who actually live in Huddersfield, in Kirklees. So, are the two transfer of care hubs, or is it a seamless service across the two boroughs? I couldn't really get a picture of how that operates from the description.
Yes, certainly, Chair. Would you like me? Sorry, would you like me to respond to Councillor Hutchinson's point?
Yes, please. Yeah, thank you.
Yeah, sure. There are daily hubs, discharge to assess hubs, that take place within each hospital. And because there are officers that work across or work with each other across HRI and CRH, particularly for people who are in wards in HRI that are Calderdale residents, there are joined up discussions on a daily basis across the system about how the person is going to be supported to be discharged. That is 5 days a week.
Southeast on Meadow Crescent, then turn right to stay on Meadow Crescent.
Not me.
Shazad, you're not on mute.
I think he's on Meadow Crescent, not on mute, by the way.
Apologies, guys. Apologies.
So that takes place, there are individual hubs or separate hubs within each hospital, and then discussions across the hospital for people who need to move where their place of residence is in Calderdale and or Huddersfield. It doesn't work at weekends at the moment, and that's always been a sticking point. And moving forward, part of the what I've included in the report was, and I didn't include what they all were, which I can for future reference. It's called a high impact change model, and one of the 9 elements is about 24/7 services, so that the way that services work in terms of discharge and prevention of admissions Monday to Friday should be working the same on a Saturday and Sunday. In truth, that's not the case at the moment by any means. Discharges are very much less, and those hub meetings don't take place. But the approach with the investment is that in time, sooner rather than later, and I haven't got a date for this, it will be 24/7.
And bank holidays, which particularly during the winter tend to come quite close together and always cause absolute havoc. Can I just one final one, Chair? That most people who are being discharged from hospital won't be fully recovered from the illness or event that landed them in hospital in the first place. So what we've heard is largely aimed at the social care element of the process. You know, if Calderdale Council has taken on the assessment for all people being discharged in the intermediate care reablement pathway, how is their need for ongoing medical care assessed and monitored? Things like wound management, treatment for neurodegenerative conditions, palliative care, you know, pain relief and all that. You know, how is that actually brought together under the one umbrella of the system?
Yes, thank you. Where I probably didn't put the emphasis on those areas was probably because I was writing this and looking at this from a social care perspective, but there is equal emphasis, and this is how the urgent care and response team has been developed on those areas, so that there is a lead clinician within the urgent community care response team in the community, and other clinical roles as well as social care roles that are identifying and working with in partnership with the GP, of course, the clinical concerns, presentations that the person has. And again, health colleagues will be able to give more detail in respect of the question that you've asked Councillor Hutchinson than I can. But there is an equal emphasis to make sure, because most of these people have, as I referred to earlier on, they are, you know, it's medical terminology, but they're medically optimized, which can mean a lot of things, but essentially the person can still be incredibly frail, incredibly unwell, suffering from delirium, but still from a medical perspective, in a position to be discharged home, or, you know, potentially if it's not safe, to a short-term placement, discharge to assessed placement. And that's where the clinical roles will kick in to support that with this future model.
Because the government guidance specifically says that patients should have a point of contact if they are having problems with their medication and the like, and they should not be advised to see their GP or go to A&E. And it's very clear about not contacting the GP, that should stick with the discharge team.
Yeah, there's a practice lead. Sorry, I've forgotten the full title, but there is a practice lead clinician, that's not the right title, my apologies, that is situated within the UCR that would be that point of contact, or he or she would ensure that there is a clinical point of contact for that person and or family if it wasn't them primarily.
Thanks for clarifying that, Sean.
Thank you.
Thank you, Sean. Councillor Kingston.
I just want to push that a little bit further because it relates to what I was going to ask Sean. I think you might have answered this, maybe I've not picked up on it. These hubs are not 24/7 at the moment. That's the aim. Councillor Hutchinson was asking about a point of contact and has pointed out that the GP cannot be a point of contact. That's why I first put my hand up, because you mentioned the GP earlier and I had alarm bells ringing galore, because we know that people are finding it very, very difficult to contact GPs, and somebody in this situation shouldn't be being told to contact their GP, in my opinion. So I just want to check, is there 24/7 a point of contact for a person in this situation that has been discharged home and but is still unwell and still has ongoing medical needs? Is there a 24/7 point of contact available to them?
Yeah, that will be the purpose of the Urgent Community Response Team, which is called UCR, but the Urgent Community Response Team, that isn't 24 hours itself at the moment. It only runs from 8 to 8, but that will be extended to 24 hours. But there is a contact number there through Local Care Direct, 24/7. So that, again, if the person and or family need a clinical contact or a contact, they can access that through the number, which is 24/7.
So they're not going to be waiting on the phone for 2.5 hours for an available GP. Fantastic, thank you.
No, they shouldn't be.
Thank you, Sean, for clarification on that. Councillor Pritchard.
Yes. What effect do you think the changes to Schedule 3 of the Care Act, which revokes the procedural requirement for authorities to carry out long-term health and care needs assessments before a patient is discharged?
Well, all the evidence would suggest that it's a good thing. In that when, and from my experience as well, so there's professional experience and personal experience, assessing a person in situ in a hospital, most or if not all professionals would say it's not a good environment, because you're getting a false impression, particularly if the person has kind of behavioural presentations and physical comorbidities as well. It's not, in terms of the familiarity, as I said earlier on, of their environment, it's not a good environment to do a full assessment, and that has been the consensus for some time, hence the push behind this model. So supporting a person and assessing a person in their home environment is probably going to give you a much better impression of how they're going to cope and hopefully, recover some of their independence, rather than in a ward. And particularly if members of the committee have been in an older people's ward, the difficulties of professionals and families to try and support and manage their loved ones is really difficult in that environment. It's so unconducive. So the evidence, the evidence in itself, as well as, the gut feeling that it's the right thing to do as well, which isn't, good enough in itself, would be in situ at home. So I'm, from a professional perspective, I'm certainly supporting that approach, and colleagues would across the system, I'm sure.
Thank you.
Thank you, Sean, for that. Councillor Hutchinson.
Thank you. I understand the theory and the thinking behind it, because hospitals have been turned into places that are not terribly healthy to be in for very long. They didn't necessarily they weren't always like that, but that's what they are now. But I just wondered what you feel are the main gaps in the system as it is currently that need to be filled for the system to actually deliver its full potential. So where should we really be directing our attention to beefing it up so it can be as effective and as safe as possible and supportive as possible?
Yeah, I mean, my view, and again, I think this is the view of colleagues that I work with, is that one of the biggest issues, and you've raised it already, Councillor Hutchinson, is the fact that we don't have a 24/7 approach to this. And we will in time, but it's a very glacial approach. So we've got 2/7 of the week knocked out really. Obviously we have colleagues in the system, but it's not as productive as it could be to support people to get home. We also have, in terms of agenda for change, a very kind of difficult system to kind of change as far as workforce terms and conditions. So the shift of moving professionals from the acute setting into the community is a real task in itself, and it hasn't been completed by any means. I do think colleagues in the health system locally have moved heaven and earth to get to this point, and it's taken a long time. But I think if we can shift much more resource as well as work much more closely, which we still need to do with our voluntary sector, and importantly for me, and I think I shouldn't speak on behalf of Kath, but Kath and I come from the same angle on this really, we're cut from the same cloth. You can discharge someone and it can be the best clinical and social care assessment that you can have. But I've seen some cases recently or some situations, I should say, where the person's link with their communities, because their conditions have deteriorated, be that mental or physical, have been lost. And what we're not doing as a system is rebuilding or ensuring that the links that those people had with their networks, with what they did prior to their conditions deteriorating, we're not supporting that in terms of what we've discussed across the system as a strengths-based approach. But essentially, that just means linking people naturally with the communities that they were always part of, but they're not anymore just because they're ill. So I would say if we could break down the strictures, the constraints within the health system in particular, to move more resources there. And what we're doing already in adult social care and with the council more generally, with health colleagues, link people with their communities so that they feel part of it and not just stuck in a house that is their own, would be the best shifts that we could ever make, I think, or not ever make, but significantly make.
Yeah, is access to the community equipment store, the loan store, 7 days a week?
Yes,
it is. So there is needs a commode or a toilet seat raise or something. They can get it. They don't have to hang on for the weekend over the weekend.
No, absolutely, and that's one of the performance indicators that there will be in this list of metrics that we discussed before. But Calderdale has always been a very high performer in respect 7 days a week of ensuring that people can access equipment. The loan store itself isn't open on a Saturday and Sunday, but there are hubs that are available for practitioners to access that to support discharge counselling.
Okay, great, thank you.
Thank you, John. Kath says, hopefully we've got connection. I don't think we have, I'm sorry, no. If you want to put something in the chat, if you can do, and I'll read it out. In the meantime, I'll bring in, there was somebody else's hand up.
That was mine, Councillor Hutchinson, that's the question, so I've dropped my hand.
Superb. Okay, so it's fairly clear that this is evolving. It's almost like a moving escalator. We want to know, we want to know if it's successful. We want to know the journey of this. I want you to take us along the journey of a patient eventually, and tell us that actually these things that you've got to put in place are going to actually work, and are going to be simplified to the patient. And we all know what's happening as well. So I think we very much would welcome you to come back at a later stage in the process when everything is hopefully up and running, when it is 24/7, 7 days a week, because that's really a key. I'm just going to bring back in Councillor Hutchinson.
With that review, can we also hear from Health Watch directly at that time to see?
Yeah, indeed, absolutely, Councillor Hutchinson. I know, Sean, you've probably seen sight of the Health Watch reports with examples, and I'm sure those are just a few examples of what people have experienced. It's a very stressful time for these patients, and I think we've got to put ourselves in their shoes. Is actually they're not feeling the best. They've got and they're looking after a relative, and we just need to ensure. Kath's busy away typing away, so I can see her typing away. I'm just holding off to close this item, but I do want to read whatever comments she's got. So I'm just, if people can be a little bit patient, and then we can. So we do want to put this back onto the work programme, so we along the way and deal with all the items that are being put forward. And hopefully simplification from our point of view as well. So hopefully a few nice charts. Right, so thank you, Kath, for that. Sorry, I just wanted to support what Sean said. I think the biggest shift we need to make as a system, and which will have the biggest impact, is a community-led, strength-based approach, which ensures the person is at the centre of planning and produced where possible. So yeah, it is about the person being in the centre. I totally agree on that. Sean, do you want to come back on that?
Yes, just very briefly, Chair. Would it be suitable or appropriate for the board to, once we get through winter, if there were a review, as Councillor Hutchinson had said, but an update post-winter on how the model has worked in respect to the questions or the challenges as well that the committee has presented?
Yeah, absolutely. As soon as, basically, Sean, that will be most helpful. Just for Michael Lodge, Health Watch were invited to the meeting, but unfortunately couldn't make it. But we'll ensure at a future meeting where this is discussed that they are in attendance. So thank you, Sean, for answering those points. We now go on to item number 7, which is just charges policy for care and support services. And it's over to Kath. It is coming here. It's going to full council in September. It's then coming back to this scrutiny board, where we'll have the opportunity to make comments. But we wanted the opportunity, the earliest opportunity, so we could invite Katie Clark to the meeting to express her views. An experience, I guess, in some way. So Kath, we've had the reports. I don't know if you want to add anything to that to give a bit of an all-round situation. Although you're going to probably struggle. So.
Sorry, Chair. It's I'm used to working with Teams, and I'm hitting the wrong button with Zoom, so my apologies. Would it, and it will be very, very brief, so that the committee can ask the questions rather than me drone on. Just highlight the reason for the report, or the points in the report. Essentially, we haven't had a policy in place for some time, so therefore that hasn't been helpful in any respect, certainly for the council, but most particularly for people in receipt of care and support services. And what these suite of policies would do in terms of people receiving residential care, community-based services, also debt recovery, which is another element of this, and there are lots of sensitivities around that, and the direct payments policy, is to make sure, quite rightly, that we're statutorily compliant, and that even though we have been previously, we haven't had a policy, which we should have had, to kind of cover that, to give that oversight and to make sure that we are compliant and transparent and fair. Hopefully this will give more consistency to people in receipt of care and support services who will receive charges, and that we, it's complicated and it's highly sensitive as well, but it is about making sure as well that people's income is maximised in terms of their benefits that would pay for these charges, and it's a very emotional issue too, and that we are doing that in partnership with people who use our services.
Thank you, Sean. I'm going to bring in Councillor Fenton Glynn, the portfolio holder, first of all. They're bringing members in, then Katie, I'll bring you in if that's okay. I'm just trying to manage it very fairly.
I just thought I'd give a bit of, also just kind of add to that context. So obviously this has been through Cabinet and it will go to full council. But what's been to Cabinet is that we've reviewed the policy, some of the suggestions of what we're going to go through, but also then that we will consult on it. So whilst, obviously we, I guess technically can't consult on it until council has told us we can consult on it. These kind of views from your board would be very welcome in terms of our thinking about this consultation. You know, we don't presume to be right first time, but what we are trying to do is trying to refine it and make it better. So yeah, as I say, all your views are really welcome, and we come in the spirit of listening.
Yeah, thank you, Councillor Fentington. That's most helpful to set the context. Councillor Kingston, first of all, please.
I'm not sure, but I think that Katie is probably going to say some of the things that I was going to say. I wasn't aware that you were going to join us, Katie, and I'm really, really pleased to see you.
Indeed.
That's fantastic. Shall I just say what I was going to say?
Yeah, do. Yeah, please do. Yeah, please.
Yeah, just that I read the reports, and because of Katie, I was at a recent event about social care that Katie invited me to. I had the privilege of sitting with her, so I think I might know some of the things that she's going to say. I read the report and I went and looked at the Social Care Futures website, what they have to say about direct payments, which is, I think, probably one of the things that Katie's going to talk to us about. And it talked about how use of direct payments has flatlined in recent years, a lot because of austerity, possibly. But also it said that people who continue to use them, while not wishing to give them up, report increasing control and scrutiny by councils, including via the routine use of prepayment cards and apps, a lack of flexibility about how they may be used, burdensome red tape, and real challenges hiring and retaining staff. I think those are all issues that Katie's probably going to talk to us about. But when I read the report about direct payments in the reports pack that we received today, I was really alarmed because all those things featured in that report. I could see that this was very burdensome. There was a lot of control over what the payments could be used for, how they could be used, who could be employed. I was really alarmed, and I could see why there is so much horror, discontent about direct payments in Calderdale. So I'm behind you all the way, Katie. Thank you.
Sean, do you want to come in on that? Or?
Yeah, it would be helpful, and I know it's a struggle for Kath, but she's bursting to make some comment as well. Hopefully, I can do that on her behalf. We are between a rock and a hard place. I've worked in adult social care services for kind of 30 odd years, and when direct payments, personal budgets came in, it was fantastic, and I was involved in the In Control pilot in the early days. And as my career's kind of moved on, I tried to kind of debunk as much as possible the bureaucracy that was mentioned at the event that we had on the 24th of July. And I've had lots of conversations with people in Katie's situation and people who use services to say, what is all this bureaucracy about? Unfortunately, there is guidance that the government has said that we need to have in place, hence a policy. But the real spirit, the genuine spirit here in Calderdale is that we want to make sure that we can interpret that bureaucracy as such, that policy, in the right way, so that we can cut to the quick as far as supporting people with direct payments, where it's true in Calderdale, it has levelled off, and it's absolutely true that we haven't got it right to date. We're working with Social Care Futures in a pilot following the 24th of July event that we had, that's called Wiring and Plumbing. And essentially, it's about how we can co-produce with Katie, and sorry, I shouldn't name you personally, Katie, but the people who represent direct payments, who use direct payments, to try and take all of the, and we'll be working with 6 other local authorities to try and take as much of the bureaucracy away and come back to the essence of direct payments, which the government said of the day was about promoting choice and control. And Kath and I are absolutely passionate about that, because it is not the case in Calderdale that we have that, but that's what we're going to work on.
Okay, thank you. I look forward to hearing from Katie. Thank you.
Thank you. Councillor Hutchinson, please.
Thank you. Trying to put myself in the place of somebody who might need access to care. and having gone through the 100+ pages of documents that you gave us, I just wondered how you actually approach working with a potential client to make sure that they are sort of, as you say, maximizing the allowable income, gaining access to all the various sort of not grants, but you know what I mean.
Yes.
They might be, and that sort of what are disability related expenses that they might need to claim. How, you know, short of making it a three-way conversation with their accountant there as well, how do you actually approach this? And if you're trying to, what kind of information do you give a patient to consider, or client to consider, when you're starting off those conversations?
Yeah, there are a number of ways now that we haven't to date. We've got a long way to go, in truth. I'm not going to sugarcoat this as far as our processes and systems are concerned. But what we have at the moment is a manual process, and it's called MIG. It's maximising a person's income. And so when a person has been assessed to receive care and support services, and there is the likelihood of a charge, then a person goes through with them what their income is, and you know, and all of that kind of laborious, as you said, really, that all the information that has to be given to then come up with a calculation as to what the charge is. Our new way of working, and it will be part of our new case file recording system, but we're going to have that, we've got it in place already now, as far as charging is concerned, is that a person can, as happens in other places, they can put the essence of their income in and whatever else it might be, and there'll be a response as far as the system is concerned. There are algorithms there that will come back with an indicative amount of, potentially, in terms of the support the person is receiving, as to how much he or she would receive as far as the charge is concerned. At the moment, it's incredibly bureaucratic, very manual, and very time consuming. But the work that we're doing and the investments that we're making with the new system is about making that much easier. So in the way that we can with other organisations that aren't public necessarily, but with insurance and various other things, we can put the essential information in and come back and receive something back that is more or less an indicative amount of what we would be charged based on our benefits and so on.
Okay, I think that's the...
Thank you, Sean. Councillor Prashad.
Yeah, it's well, I've got a comment and then a couple of questions. The charges policy, I mean, we've had it for a couple of weeks now. It's a very long, involved document, and it needs careful reading. And I'm only halfway through it, principally because I'm on other committees, but it's something which I care deeply about. I just hope that this is not pushed through too quickly without careful consideration. So that's my comment. My question is about complaints. If somebody has a complaint that they've not been assessed correctly, they have to write in. Is action suspended until that complaint is dealt with?
Yeah, do you mean in terms of the charge?
Yes. Yeah.
Yes. So that if there is an ongoing complaint about the charge, and if the person hasn't started to pay that charge, then that will be looked at. It depends on the nature of the complaint, really. If it's a significant issue, then it will be suspended and a discussion will take place. But it really depends. I'm not trying to fudge the question, but it really depends on the circumstances of the individual and what the complaint is about. You know, certainly there have been a number of situations where we have suspended because we felt it was the right thing to do, the charge, until we've got to the bottom of what the issues are, and then hopefully, or there might still be some disagreement, then the charge is being kind of re-invoked.
Okay. And the second part of that is there a current backlog of complaints with the charging assessment team?
Yes.
And how long is that?
I don't know. I'd have to get back to you on that. But there are always, because of the way that the system has been designed and the fact that it's overly manual, as I said before, far too much delay in the system that we are working on. And therefore, when complaints come through, the people working on the system are also responding to the complaints. And therefore, we actually had a meeting this afternoon, Kath, myself and others, to make sure that there's a more timely response. I can't give you a number, but I can come back to you, Councillor Prasad, on that. But yes, and it can be much better than it is at the moment.
Okay. So then you wouldn't know the average amount of write-offs per year?
I can get back to you on that.
Okay, thank you. Thank you.
Thank you.
Just quickly on that, would an average make sense given that it's a new charging policy? Like just in terms of write-offs?
I think probably, are you looking for historic, Councillor Prasad? I've lost you on screen. I can't find you. Yes, oh yeah, there you are. Yeah, so probably looking at historic, but as the new charging policy may have a different carry on, because it's probably more clearer. So thank you, Councillor Fenton Glynn. We'll look into it. Sean, do you want to come back quickly on that?
Yeah, sorry, very briefly, Chair. There is, and again, it's a very sensitive and emotional issue, or motive issue. There are, at any given time, we're dealing with a number of people who plainly refuse to pay any charge whatsoever, which compromises the income into the directorate to some significant degree. And therefore, we often look at either potentially this whole process of a write-off, or it could be that we may need to pursue that if there isn't good reason. So again, it's a complicated, difficult, sensitive issue, particularly when it comes to a person's income and a charge for the care that they receive.
Thank you, Sean. So I'd like to welcome Katie Clark. First of all, before we continue, I'd like to pass on my kind regards to Nadia. I understand she's starting university this time, so good luck. I hope everything goes well with that. So as always, you're always welcome to any committee I serve on. So over to you for the next few minutes, Katie.
Yeah, no, thanks so much. And thank you to everybody who's made those really insightful comments about the policy, and thank you to Councillor Barnes for inviting me today. And I'm speaking on behalf of recipients of social care throughout Calderdale and members of our direct payment user group. This is a topic that I'm very, very passionate about, having worked nationally around unfair care charges and around direct payments for many years. And like everybody else says, it's 100 pages and I only got it yesterday, well, last night. So I'm going to talk about our immediate reaction to the policy, and then also some of the issues facing direct payment users currently and our views on co-production. But as it stands, too rightly, that Councillor Kingston said, this will generate considerable concern within our community, particularly amongst those who depend on care and support to maintain their independence in their own homes. And it's disheartening to note that the proposed policy, rather than fostering a sense of support and empowerment, seems poised to unfairly burden disabled people and their families who are already facing the challenges of rising living costs, the prospect of another cold winter. And this policy, if implemented, could lead to an unfortunate outcome, disabled people being forced to choose between insurmountable debt or forgoing essential services they desperately require. Basically, for some disabled people facing hardship this winter, they'll need to choose whether to heat their home or to buy food. And this may well impact their mental health, could increase suicide rates, could leave people without care and increase hospital admissions. One of the most glaring issues with this policy is its financial assessment process, which relies on a minimum income guarantee called MIG. This has not kept pace with inflation and doesn't accurately reflect the needs of our community members. It's quite perplexing that while the policy emphasises flexibility and choice, it paradoxically presents a barrage of rules, restrictions, and penalties that undermine the very spirit of independence it claims to promote. The proposal also seems to operate under the assumption that 100% of an individual's income above the minimum income guarantee can be allocated towards charges. It feels it's a rigid approach that contradicts the fundamental concept of promoting independent living. The lack of consideration for the real life challenges disabled people face, combined with the absence of provision for discretionary uplifts, only exasperates the situation. Furthermore, the notion of flexibility is overshadowed by punitive measures and daunting procedures for non-payment, the threat of court actions, county court judgments, and benefits being effective hangs over individuals who are already struggling. The policy, rather than being person-centered, seems more concerned with legal justifications for its actions. As members of this community with lived experience, we don't want to be sidelined. We want to be part of genuine co-production from the policy's inception. And rather than an online consultation through the website, we seek face-to-face meetings to voice our concerns and the opportunity to challenge this policy. We want a meaningful consultation where we're heard and acknowledged, rather than be subjected to a top-down approach that fails to account for our needs and perspectives. So that's just in the last few hours of trying to attempt to read 100 pages. I've got now some comments that I'd like to go on to from other members, including June Eaton from Hebden Bridge, who's very active on our direct payment user group, who unfortunately was unable to come due to ill health and going away. She also makes comments about the policy, which she feels needs to be produced in concise, plain English, and we need an easy read version, possibly other formats too. And she has a question that she doesn't know whether this is addressed in the new policy, but direct payment users have their care charges deducted from the payment they receive, and they have to pay their charge into a direct payment account. This is instead of paying the care charge directly to Calderdale Council in the same way that all other community care service users do. This makes direct payments auditing very difficult and is inequitable, and it needs to be changed as soon as possible, in her opinion. So moving on to other direct payment issues, just very briefly, we know that personal assistants are a lifeline for so many. They are skilled, flexible, person-centered, and should be highly regarded in the general workforce. Unfortunately, we're left on our own to advertise, recruit, employ, and manage teams of personal assistants with very little support or guidance. Someone from the membership of the direct payment user group sent this yesterday. She says, an easily accessible contact for information for individuals and carers, someone with knowledge and solution and ideas for support, which can avert things that are going wrong. She says maximum flexibility to use direct payments creatively, as like Sean Cook rightly says, and it needs to be flexible. And in this way, it needs to be around, it could be a cleaner, it could be a bookkeeper, it could be someone to give me time off to do all the specific physical caring that my sons need, and only I can do, while allowing me a life of my own. She says, I'm sinking in admin and washing. Don't take family carers for granted. Supporting them saves the council money in the long term. And like all of us, she says, decent rates of pay for carers to aid recruitment of skilled, experienced individuals. She wants emergency plans in place so that a fiasco, like the handling of a situation like COVID, doesn't mean that disabled people and their carers are left high and dry. So the biggest issues for direct payment users are recruitment and retention of staff, which of course directly relates to wage rates. Lack of information available either on the website. The council website has a section on direct payments. The information there is poor quality, it's inadequate, it's incorrect, and is misleading. Calderdale needs to take a good look at the Care Act and themselves. DP information, direct payment information, needs to be clear, it needs to be easy to use, with possible links for support. Other local authority direct payment sites are informative, proactive, are supportive around recruitment. And it's also important to keep these updated as required and to follow current guidance. On a positive note, the Disability Advisory Group during COVID worked well. It was unfortunately disbanded by the local authority. However, we've set up a direct payment group, and feedback about the group is extremely positive. One member said, "The group gives you confidence to fight your corner a little bit. We've learned that you don't have to be grateful for what you are offered, and you can ask for more." The direct payment group wants transparency and a proactive approach to the queries and issues that we have. It hasn't been possible, and although we've tried to get clarity in a number of things, from payments to care agencies, to payments to direct payment users who are living in rural areas, we've had few answers, and we're still waiting on a number of our queries and responses. We hope that co-production becomes meaningful in Calderdale, and we're part of the policies and guidance that affect our lives, rather than 10 minutes at scrutiny. We want lived experience representation on strategic group. We want to be able to speak to commissioners and find out who is actually approving care providers, because we want choice and skilled carers with an understanding of culture, religious needs, autism, ADHD. We want to know how commissioners hear from the people who use their services. And we want to know that commissioning is effective and high quality. So we hope that this will be the beginning of more regular meetings and involvement of local disabled people and family members, because we want services that meet our needs rather than lip service. Thank you.
Thank you, Katie, and thank you for being so concise. I wanted to keep it to 2 limits so people could actually absorb everything you were saying, rather than actually, sort of losing part of what you said. And you've possibly written that down. And if you have, I think it will be really useful to send it across to somebody. Just before I bring in the other members, I'm just going to Kath kindly wrote something in the chat room, so I'm just going to read it out so that people are aware. So the charges policy is necessary to make sure we are legally compliant and we have a good governance, etc. However, the procedure for staff are being worked on and can be co-produced with people with lived experience to simplify and guide the application of the policy in a person-centred way. And the project that Sean mentioned will really help to get rid of unnecessary bureaucracy. So Katie, I really would like to thank you for pointing out some of those really important issues. And actually it's really important that we listen to people like yourself. They've got that experience, and we take it forward. And certainly, from our perspective, we want to work with you to ensure that actually the journey is a bit smoother than what it has been previously. I think that's the element. I think certainly council acknowledges that it's been challenging. I was first involved when direct payments were introduced. I was certainly encouraged to say that actually these are going to be a really good thing. I quite agree. People that have been involved, it's the bureaucracy behind some of the issues, and I think I personally would want to ensure that actually it makes it easier for the person, rather than thinking actually it's more work than it's more hassle than what it's worth. So really appreciate the comments, Katie, and I'm sorry I've limited you to 10 minutes, but I think it was important to just keep focused. So my apologies if that's the case. Councillor Barnes, first of all.
Yeah, a couple of things. I think first of all, I think I'd also like to put my thanks to Councillor Bragborough's chair for when I made the invite and made the offer to Katie. Howard was very quick at agreeing with that without a second thought. So thank you to that chair. I'd also like to thank Katie. If that's what she's done in one day or less than one day, you know, that was a mighty impressive performance, Katie. So thank you very, very much. And I think obviously you have spoken to other members of the group, and you have managed to speak to the members of the group, and it is important. I think it's vital, and this is why I and Councillor Ragber wanted Katie here tonight to hear her views and to give other councillors, you know, that foresight, that thought, that in-depth involvement from somebody who lives and breathes this. And that, I think, is vital for us to go forward in shaping it. And you know, we hear a lot about co-production, you know, and it's a term I physically hate, to be brutally frank with you. I hate quite a lot of terms that we tend to use. Unfortunately, I'll end up using them at some point. But actually involving and using the experience of people should help us shape policy and procedures better. I didn't want to speak before Katie. I've got a number of issues with this report, but I think what we need to look at now is the next stage, and I think we really need to, rather than nitpick and go through it. And I don't mean nitpicking in the sense of Katie, but nitpicking and saying, "Oh, I don't like line 3" and stuff like that. It's really now, how do we, as a council, and how do we, as a scrutiny panel, scrutiny committee, make sure that we deliver the best result for those people who are the recipients of direct care, for example, but all direct payments, but also individuals who want to get on to that ladder. You know, Councillor Kingston mentioned the prepaid, you know, our preferred method is prepaid card. I don't personally, I don't understand that. I really genuinely don't understand that, because that assumes that people at the other end can accept a card payment. You know, they might not be able to. So I think there are things that we need to look at, but I would like to express my heartfelt thanks for Katie for coming on today. No. Thank you, Chair.
Thank you, Councillor Barnes. I'm going to read, but probably not as eloquently as Kath Gormley would read it out, because I will read her comments in the chat room. So thanks, Katie, for your articulate description of the impact our policies and how people experience of our services. We in adult services are definitely taking a close look at ourselves, and you have my personal commitment to co-production. Sorry, Councillor Barnes, on that one. So thank you, Kath, for putting that in the chat room. Councillor Kingston is next.
Thank you very much, Katie. That was excellent. Well, very, very well articulated. And some of the words used are words that I've made in my own notes. You used the word punitive, and that's on the doc. You know, I annotate the documents, and that's on. That's one of the annotations I've made, that I felt it was punitive. I didn't like the whole sense of suspicion that surrounded it. What I read there was suspicion of people in receipt of direct payments, that it was just loaded with suspicion that they were going to misuse this money somehow. There was an air of a lack of trust in their ability to decide for themselves what to do. I totally don't understand why family members are precluded from being paid for care. That makes no sense to me whatsoever. Why is that in there? And the prepayment card issue that Councillor Barnes has already raised as an issue. Punitive and suspicious. It felt frankly disrespectful to people who are living in Calderdale with disabilities, with needs relating to disability. It felt very disrespectful of them. And as I said, I was horrified reading it, very uncomfortable to be a member representing a council that puts out documents like that, policies like that. Can we not rewrite it? Can it not be rewritten with some compassion in there? Is that not possible? Thank you.
Thank you, Councillor Kingston. I'm going to bring in Councillor Hutchinson.
Yeah, thank you. Through you, Chair, is it possible to ask Katie a question?
Yes, I mean, of course. She's willing to answer it. She may feel that she needs to go. I'm sure. I know Katie will have the answers off the top of her head. So by all means, Councillor Hutchinson.
I mean, I fully understand that a large part of the policy is driven by the legislation that the local authority has to work work under, and that's what really shapes it. But you were saying that there are some local authorities that have websites that are far more informative, user-friendly than we do here. Can you give us examples of local authorities where your contacts, your members feel they've got this right, that we can maybe take a look at and see what, rather than reinventing the wheel ourselves?
Yeah, I can do some research and get you some local authorities that are doing it right. Kirklees has a great Facebook page and a really helpful website for employing and recruiting new personal assistants and carers. I actually went on the Calderdale Cares partnership career pages, which is really out of date. And some of the job adverts are like 10 months old on our own website, and it has got potential. And I had asked if we could advertise for personal assistance on their website, as it's a resource that's already there, and was told that you can't for direct payment users. So I think learning from Kirklees and how they advertise and their support, in fact, even though living in Calderdale, they give you a call, make sure that the advert looks right when they send it out, and then they phone you to see if anybody's applied for the job. So that's just across. So that's one really good example. Also, can I just say about a tool? There's a really useful tool to help people around their care charges that's just been produced by Inclusion London. So that might be something that we can share with direct payment users here.
Excellent. Thank you, Katie, for that. Sean, can I bring you back in, please?
Yeah, just very briefly, I'll be very, very sorry, Councillor Bagber. The project that I mentioned earlier on that Katha mentioned in her comments too, we're really hoping that this is going to be the driver to address a lot of the concerns and issues that have been raised by Katie and by members of the committee. I'm not sure if I mentioned it, but it's called, it's got a great title, it's called Plumbing and Wiring. But the focus will be, for us from a Calderdale perspective, will be on direct payments. And we will be, literally inviting people using direct payments through support from Katie as to how we can co-produce the whole system that is much more user-friendly than it is at the moment.
Thank you, Sean. As I say, once again, Katie, thank you so much for coming along.
Thank you.
And for being so understanding as well, but actually put it as it is, and that's what we want to hear. What is the end user experience? What is the person at the other end who's getting the direct payment? How are they experiencing it? And that's you bring it to life, and I think you have done with the officers and certainly members around the table. So it's extremely important. As you're aware, it's going to full council meeting, and then it's coming back to our scrutiny in October. So that's not a closed door. I'm not saying, our door is open for other comments as well, if you'd like to feed those into the process. And as Kath as rightly said, and Sean, that actually we do want to work with yourselves as a key person in the community experience these types of issues. I'm sure other members will be in agreement with that. So thank you.
Yeah,
thank you.
I'll leave you all for the rest of the evening, and thanks for inviting me.
Absolute pleasure. No time. Yeah. Thank you. Take care. Okay, so let's go on to item number 8. In that case, it was the Health and Wellbeing Board Chair's report. So I'd like to welcome, when I can see him, sorry about it, my apologies, Councillor Swift, you there. Welcome on board. You do an extremely important role on the Health and Wellbeing Board, and you have done it for quite some time. So if you'd like to present your report, that would be most helpful.
Thank you very much, Chair. So I think this is the first time that we've presented a report from the Health and Wellbeing Board to Scrutiny. I think that's a good opportunity, but obviously looking forward, one of the things looking for a steer from is perhaps what Scrutiny would most want to hear, because we made this fairly much of an overview of what's happened over the year and not repeated a lot of the detailed discussions. And theme I'll return to shortly about the role of the Health and Wellbeing Board in a moment. So brief headlines, a key responsibility for the Health and Wellbeing Board is to make sure that there is in place a wellbeing strategy which is shared between the local authority and our health partners. And we adopted a refreshed wellbeing strategy in December 2021. And what we tried to do with that was be a little bit more focused about specific goals. So the previous health and wellbeing strategy had something like 12 different priorities, for example, and you'll have had this discussion on other things. If you only have a small number of priorities, people always ask why something else isn't there. And if you have a large one, they ask why there are too many priorities. So we've tried to be very focused. We've looked at sort of the 4 stages of people's lives: starting well, developing well, which is sort of the period when of school age, if you like, living and working well, because we recognise that health and well-being amongst the working population is incredibly important, perhaps something we're becoming growingly aware of the pressures as we start to see the rising number of people who are unable to work or unable to work fully because of health challenges. And then aging well, which is much more than simply care for older people, but is about all the different ways that people as they age contribute to society. And with each of those, we tried to challenge ourselves really to focus on one specific priority, which is children being ready for school. And I think probably the most interesting discussion when we were setting the strategy up was around developing well, where we ended up with this target about every 15-year-old having hope and aspiration. And it was really interesting because actually the drive for what might feel quite an unusual form of target very much actually came from one of the GPs on the partnership. So very much came from the health side, saying, let's not focus on the negatives. What do we really want? We want our kids, as they're getting to the age where they're thinking about what they're doing post 16, to feel positive about the future, to feel they can have a sense of hope and aspiration. And what are the things we need to do in our education system, in our support for young people, in our work with young people with challenges to make that a reality? We have an update on each of the areas of work, and there are, as you would imagine, there are partnership groups looking at the work in each of those areas. We have an update on each of those areas at each meeting, as well as bringing forward a number of topical issues. Health and Wellbeing Board is a bit of an odd body in constitutional terms because it is effectively a council committee, but at the same time is also a joint committee with health, and is a bit unusual in not being either executive or scrutiny in a sense. It sort of sits between the two. And what we try to do is make sure that our role is looking at what's happening in the system and identifying gaps and challenging what's going on, not repeating what is done elsewhere. So, for example, we will have a report annually from both of the safeguarding boards, but we try to make that not simply a rerun of discussions that are happening within their board, but very specifically ask them to talk about the weaknesses and the gaps and what we need to do together as a system. The other thing that's changed in the role of the Health and Wellbeing Board is that as the integrated care system has come into place at a West Yorkshire level with place-based structures, clearly our relationship previously was particularly with the Calderdale commissioning group. That's now rather replaced by delegated role from the ICS and particularly the Calderdale Cares Board. And if you like, the Calderdale Cares Board is about delivery. The Health and Wellbeing Board is strategic. In addition to our formal meetings, we have a number of informal meetings during the year because they provide really good opportunities, again, to get a group of people together across the different elements of the systems and just have a really good open and honest debate about some of the issues. And sometimes those then turn into a more formal report to the committee. So you have the report there, you have a summary of the topics and the issues that we've talked about in the recent meetings. Be helpful to know if this is the kind of scale and length of report you would want in the future, but very happy to sort of take any questions and comments, Chair.
Thank you, Councillor Swift, on that. That was most helpful, and thank you for the reports. Most helpful to see where you've sort of been. I sort of understand because I have served a few times on your board, so always interesting. Councillor Hutchinson.
Thank you, Chair. This may be a slightly unfair question. I hope not, but the Health and Wellbeing Board's been going for quite a number of years now. what do you feel are the main achievements that have that it's actually delivered over the last few years?
Councillor Swift, do you want to respond to that, or do you need a bit more time? There can be a delay in the system.
The main delay, like everybody else now, is getting used to Teams and then forgetting how Zoom works. So I couldn't turn my microphone off. Yeah. No, I think I think it's really interesting. It's an interesting question, because an interesting question what the board's role is, and the danger is we then find ourselves kind of cherry picking and claiming credit for things that are going on in the system, and then inviting the comment of would that have happened anyway. So I think in a sense the most important thing health and wellbeing done is change the culture about how health and the local authority see their relationship, from one of separate bodies to seeing where those their shared interests in well-being are, and Councillor Hutchinson will quote better than me the stats about what it is that really leads to good health, and most of that has nothing whatsoever to do with health services directly. It is about all the things that contribute to health and well-being, and seeing the connections between those. I think I mentioned the sort of growing focus on the importance of health and well-being amongst people of working age, and I think that's that's a good example of the way we've seen those connections together. I think our work's got slightly disrupted, as lots of things did during 2020-21 by COVID, and we got very focused on particular problems. I think the most important thing we add into the system all the time is a challenge to say, how are we making the focus being on making people better? It's not about fixing things when things go wrong. It's about what is it that leads to better health for all as a whole. How do we keep the focus on prevention and well-being and stop that inevitable shift all the time into the focusing on the needs of people with the biggest problems.
Yeah.
Thank you, Swift. I'm also quite impressed with the actual makeup of the membership, actually, because it covers a spectrum of all the different groups that sometimes we're not careful, something slips by the by. And I think this way it doesn't appear to anyway, certainly from my perspective. Councillor Ruthron, would you like to come in?
Thank you very much, Chair. I'm slightly preempting something that will be coming to Health and Wellbeing, that will be coming to Cabinet in October. I hope I'm allowed to do that. But we're involved in the Domestic Abuse Working Party, and one of our recommendations was this should go to Health and Wellbeing Board. And I think our feeling around that was just like the widespread representation. The opportunity is something that has to, by its nature, multi-agency, and it being adopted publicly. Obviously, time will tell whether that is a success, but I think sort of one thing I certainly welcomed, being fairly new to this and perhaps not really understanding about the potential of the Health and Wellbeing Board, was that was something where it could have a really important role. I hope that's appropriate, because I say I'm preempting. I don't know what Cabinet is going to make of that when it comes to in October. But I said I think being new to that, I think I just saw the potential for something that by nature has to be multi-agency, important for health of a lot of our population, and can be publicly adopted.
Thank you, Councillor Ruthron. I'd just like to personally thank you for the amount of hard work that you put into that particular report. I know you have been extremely busy, and it is an extremely important subject matter. I'm going to bring in Councillor Swift, who's going to welcome coming to the Wellbeing Board, I am sure.
Well, like Helen, I don't want to preempt what Cabinet might say on it. But I would absolutely say that there is certainly a key role for the Health and Wellbeing Board in understanding what is happening with domestic violence and domestic abuse strategies, and again being sure that there are no gaps. I mean, I think over the last few years, probably the lead on that has tended to be with the Community Safety Partnership, which is fine in one sense, but perhaps can sometimes be too narrow a focus. We have had, going back to, trouble is when you've been on the board for, when you've been on the council for a few years, the danger is you slightly lose track of things. So if I say that, certainly I'm going back to the point when Stuart Smith was Director of Children's Services. We had some quite detailed work on domestic abuse brought to the Health and Wellbeing Board at that stage. I guess that's probably going back 4 or 5 years though now, I would think, perhaps even 6 years. And, obviously one of the things that we're very aware of is the extent to which problems related to domestic abuse and domestic violence can contribute and feed into so many other problems in society. And I'm sure some of those links and connections will come through again in the report that I know is coming through to Cabinet. So very happy to look at that, Helen. Yeah.
Thank you, Councillor Swift, and thank you for presenting the reports. Extremely useful and interesting reading as well. So thank you, Councillor Swift, for coming and taking part in our meetings. It's nice to work together as always. So that concludes item number 8, which brings us down to item number 9, which is a work programme which has been circulated. But Mike, do you want to add anything to that?
I think just briefly, Chair, that at the last meeting, I said I would go away and look at the Calderdale Cares Partnership Board's transformation plan to see what particular aspects you should consider on your work plan. I have started that work, and it could be a very, very long list, but and I think it sort of ties in with some of the things that we talked about under the first item coming back perhaps in the new year. And actually we have some capacity in our work programme in the new year. And talking to I plan to talk to officer colleagues about how we make that. We don't just bring everything back, because there's I think Councillor Barnes at the last meeting said it was a very, very comprehensive plan, and it's very long. It's to make sure that we focus that properly, but certainly some of the stuff on home first and discharge to care features heavily in that plan, and we can tie the two things together about reporting back on the previous discussions and bringing them back in the new year.
Super, thank you very much for that. As always, my door is always open. If somebody wants a suggestion that they want to bring to scrutiny, always happy to consider. And as of this evening, bringing somebody else involved, getting somebody else involved, Katie Clark, who has first-hand experience of what we'd be actually discussing and dealing with. So I think it's really important that is the case. So I am now going to conclude the meeting, and actually in my mind I was going to finish at 20 to 8. So I think we've done rather well finishing at 1936. So thank you very much indeed, members.
Chair, can I just point out, in the future, please tell us at the start, and we'll obviously aim to better that. All right.
Yeah. Well. Anyway, thank you very much, members, for the extremely important contribution. Sorry, Kath, for your issues with your technical issues, but we got there, and thanks, Debs, for taking part as well. And I hope you have and Sean, of course, not forgetting Sean, who's done he's been the main man of this show. So thank you, Sean. I hope you have a nice evening, and thank you once again.
Thank you, everyone.
Thank you.
Bye.
Bye.